This audio slide deck addresses basic concepts used in payment for inpatient acute care hospital services. These payment systems include DRGs and earlier and later payment systems. Until the implementation of Medicare and Medicaid in 1965, hospitals were generally paid for inpatient services based on hospitals' charges. Payers for hospital care included Blue Cross plans, commercial insurance, and individual patients. With the implementation of Medicare, hospitals were generally paid for inpatient services through a system called cost-based reimbursement. In this system, hospitals submitted cost reports to Medicare that showed their costs for operating the hospital over the course of a year. Hospitals were paid for each admission based on the costs that were incurred for caring for that patient. This system tended to lead to higher costs. Under cost-based reimbursement, there was growth in the number of hospitals, and hospitals grew in size. Also, there was not an incentive to limit the length of stay or the type of services provided in the inpatient setting. The DRG system was first implemented in the mid-1980s in an attempt to limit the growth in the cost of inpatient care. While there are some adjustments for individual factors such as local labor costs and teaching costs, DRG rates are applied across all hospitals. In this system of payment, there's an incentive for hospitals to limit their costs. In the initial DRG system, the DRG was based on the principal diagnosis and any surgical procedures that were performed. But the specificity of the DRG was limited, with a relatively small number of CCs, or complications and comorbidities, to convert the DRG to a higher paying DRG. Under this initial DRG system, hospitals complained that they were not adequately paid for patients who had significant comorbidities. Hospitals might be paid the same amount for a patient with a given principal diagnosis or surgical procedure, regardless whether the patient had multiple comorbidities requiring much more expensive care. This could lead to care not being available for patients with complicating medical problems, or hospitals that cared for those patients having inadequate resources to continue to provide that care. These concerns led to the development and implementation in 2007 of the MSDRG, or Medical Surgical DRG system for Medicare reimbursement. With MSDRGs, MCCs were added, resulting in more DRGs representing care for the sickest patients. This provided for higher levels of payment for patients with a high severity of illness. Subsequently, 3M developed another system of DRGs called APR DRGs, or All Payer Refined DRGs. This methodology is intended to be applicable to not just medical surgical patients, but also other types of patients, such as pediatric or obstetric patients. The APR-DRG system also includes a more detailed representation of the patient's severity of illness and risk of mortality. With the risk of mortality ranking that's part of APR-DRGs, it's possible to represent the risk of death for a given inpatient on a scale of 1 to 4, depending on the patient's diagnoses and surgical procedures. With this risk of mortality methodology, an overall risk of mortality for all of a hospital's patients or all of a physician's patients can be represented. This overall risk of mortality for a population of patients can then be compared to the actual mortality experienced for those patients. If the ratio of actual mortality to risk of mortality is less than 1, this implies a favorable result for these patients. If the mortality index is greater than 1, this implies an unfavorable result. Subsequent to the implementation of DRGs and then MSDRGs, CMS has been developing new systems for paying for inpatient care. These methodologies can be referred to broadly as value-based payment. Bundled payment methodologies make a single payment that's broader than the DRG, paying also for care before and after an acute inpatient hospitalization, or also for the physician's professional services. ACOs, or accountable care organizations, involve payment for all of the care provided for a population of patients. There are numerous other components of value-based payment, including patient safety indicators, hospital-acquired conditions, readmission rates, and others. I hope that this brief audio slide deck has been useful in explaining some of the basics of the payment system for inpatient hospital care before, during, and after the implementation of DRGs.